And now I would like to introduce Dr. Tom Gill. Dr. Gill is a fellowship-trained orthopedic surgeon specializing in sports medicine, shoulder reconstruction, total shoulder replacement, ligament reconstruction, cartilage restoration, and meniscal transplantation of the knee. He moved to Memphis in 2001 and started his practice here in 2011. Dr. Gill is affiliated with athletic teams at St. George's Independent School, East High School, White Station High School, and the Greater Memphis Soccer Association. In his spare time, Dr. Gill enjoys spending time with his family. This includes watching his son play sports and usually attending as many Memphis Grizzlies games as possible. He also enjoys community outreach and seeks involvement through his church and the Boy Scouts of America. He endeavors to serve the community through sports-related partnerships such as Memphis Youth Athletics, Memphis Athletic Ministries, Streets Ministries, Girls on the Run, and Memphis Rugby. As you can see, Dr. Gill is a busy guy, but he still found time to sit down with us tonight and discuss these common shoulder issues. So without further ado, take it away, Dr. Gill.
Good evening, Melissa. Thank you very much. Thank you for that kind introduction. I also want to tell everybody a little bit about our group here at OrthoSouth. For those of you that have been in the Memphis and Mid-South area for a while, you probably know us by our parent companies, Ortho Memphis, Tabor Orthopedics, and Memphis Orthopedic Group. A few years ago, we combined forces to form OrthoSouth, which gives us 35 physicians over 8 locations to serve you conveniently. And we have 7 fellowship-trained sports medicine / shoulder surgeons here to serve you. I'm just one of those. As we move into our discussion tonight, which is going to be the shoulder. Can we move to the next slide?
Yes, we can.
When I was asked to talk about shoulder pain, I was very enthusiastic and happy to talk about this. This is something I love talking about, and probably about 60 to 70% of the patients I see in my office come in with some form of shoulder pain complaint. However, this is a very broad topic. So there are so many things in the shoulder that we could discuss. We could talk about it for hours on end. That's not going to be very functional for everybody. So we're going to primarily discuss the anatomy of the shoulder in general with a broad overview. We're going to talk about the most common causes of shoulder pain for most adults. I'm going to try to give you some guidance on when you might have just a little soreness that you should wait and see how it plays out, or when you should be more aggressive on seeking help. And then I also want to take a brief minute to discuss what an office visit looks like in 2020 in the face of COVID-19, because I think there are a lot of people that are still pretty nervous about that, and I hope to be able to put your mind at ease a little bit about what our office is doing to help keep patients safe. Next slide. As we discuss the shoulder anatomy, I'm going to start first talking about the bones of the shoulder. Most of these bones you can feel. They're the clavicle, the scapula, which is the shoulder blade. You'd feel that on the back of your shoulder. The humerus is a little bit deeper. That's the arm bone, your upper arm bone. And then these bones also interact with the ribs as the scapula slides across the ribs. So there's a lot of areas there that could lead to some difficulty from a bony standpoint. However, by and large, the bones are not our biggest concern. The big muscles, such as the deltoid, the big muscle you can feel on the outside of your shoulder, the pectoralis muscle, the muscle on your chest, the muscles of the arm, such as the biceps and triceps, and the latissimus, which is the big, broad lower back muscle, and the trapezius, which is the upper triangle muscle that you would see just behind your neck. These muscles can feel pain during shoulder problems. Very rarely are they the source of the pain during shoulder problems. Our culprits usually lie a little bit deeper with the muscles of the rotator cuff. If we move to the next slide, we'll get a little bit more detail on the rotator cuff. The rotator cuff, just so we know what it is a group of 4 muscles that all start on the shoulder blade, and then they insert or do their work on the humerus, or the ball of the ball and socket joint, which is the shoulder. Their job is to help rotate the arm, which gave them their name. It helps pick the arm up, like lift your arm as if you're raising your hand up above your head. They help hold the ball centered in the socket, which is one of their most important functions. And problems of the rotator cuff will account for the vast majority of problems that bring patients in to see me. And we'll circle back around to that in a second. As we dig just the next layer deeper, we'll see the capsule, which is the soft tissue connection between the bones of the shoulder. And next to that is the labrum, and then the bones themselves. And like any joint, there's cartilage in the shoulder joint, which can develop problems. That would lead to things such as arthritis. The labrum can be damaged either through traumatic events or just day-to-day activities. And then there are some problems that the capsule can cause, which we'll discuss a little bit later on. If we move on to the next slide. The first thing I wanted to talk about is I want to circle back around to perhaps the most common cause of shoulder pain in adults. And this is going to be problems with the rotator cuff. The rotator cuff, for the purposes of this discussion, we're going to call it rotator cuff inflammation. I previously described what those muscles do, but they can become inflamed or irritated. We call it sometimes bursitis, sometimes impingement, sometimes tendinitis. And although there are very small differences in the subtleties of those problems, they all sort of act alike. For most patients, the symptoms are going to be the same. As these muscles come into the shoulder, they have a tendency to either rub against the bones nearby, causing tendinitis or impingement, or they just get tendinitis like you would get anywhere else from an overuse type activity. As we move on to the next slide, we'll see a little bit of the symptoms that people often present with rotator cuff inflammation. Very rarely is the pain truly deep in the shoulder. Sometimes it is, but by and large, the patient will complain of pain down into their arm. They usually point to the side of their arm where the deltoid muscle comes down into the upper arm. We call that area the deltoid insertion, and that's an area of referred pain. So a patient will come in, they'll point to that part of their arm as being sore. They'll say the pain is worse at night. That's very non-specific. Almost all shoulder pain hurts worse at night. Rotator cuff pain will often hurt with overhead activity, and occasionally it'll result in some stiffness or even weakness in the shoulder. As we move on to the next slide, we'll talk about our common treatments. Most commonly, we treat rotator cuff inflammation with rest. We'll talk about this word, non-steroidal anti-inflammatory drugs, which is a fancy way to say drugs such as Aleve or Advil. These drugs help decrease inflammation and help sore muscles and tendons feel better. They're probably something many of you are familiar with. Physical therapy, however, I always describe as the linchpin of shoulder treatment. When you've got a rotator cuff that's inflamed, if you strengthen the muscles that surround the shoulder and you strengthen the other muscles that stabilize the shoulder, oftentimes you can take and offload the irritated muscle and give it time to heal. So a lot of patients will ask me, if my tendon is upset or irritated, why would I want to exercise it more? And the reason is going through that little bit of exercise helps strengthen those tendons. It helps the other muscles come online to help the shoulder work more appropriately and decrease the pain and really lead to healing. The other things we're doing are largely to help decrease the pain, such as the non-steroidal anti-inflammatory drugs. Sometimes we'll recommend a cortisone injection, not all the time, but sometimes we'll recommend a cortisone injection. And we're doing that to help decrease pain as well, so that you can do the exercises that the therapist prescribes and get that ultimate healing, which is what we're all going for. Sometimes rotator cuff tendonitis can be persistent and just won't go away with with the simple things such as exercises or our conservative treatment. So if you keep coming back and it's been 6 weeks to 3 months or more, and it just keeps persistently bothering you and not getting better, we will resort to a surgical procedure to help take that inflamed tissue off of the rotator cuff, but that's very rare that we have to resort to that. As we move on to the next slide, we'll discuss rotator cuff tendon tears, which are different than tendonitis, and we treat them somewhat differently. These tendons, like any other structure in our body, can wear out as we age. Sometimes you can tear a rotator cuff tendon from a traumatic event, perhaps a fall, picking up something very heavy, being involved in an accident or a work-related injury. All of these things can result in tears of the tendon, but the tendon can also tear just from what I like to say is birthdays and bad luck. Unfortunately, this is one of those tissues that if you live long enough, you'll probably develop a tear in it. I've seen estimates of up to 80% of 80-year-olds having rotator cuff tears. Now, I don't operate on 80% of the 80-year-olds, so just because a tendon is torn doesn't automatically mean we have to fix it. We always try to tailor the treatment to the individual. So we treat the person, not the diagnosis. So a lot of times we'll start with conservative treatment. Since this is something that happens to so many people, and very few people actually require surgery for this, your first visit where we diagnose a rotator cuff tear will oftentimes once again recommend anti-inflammatories and physical therapy, and sometimes a cortisone shot. This is another one of those times where a lot of times a patient will look at me and say, "Hey doc, if the tendon's torn, why don't we just fix it?" And that makes sense, except for the fact that so many people can get better without an operation, and it's always good to try that when it's appropriate. However, if we do have to pursue surgery, almost every time we need to treat this, it'll be with something called an arthroscopic rotator cuff repair. This is a minimally invasive surgery where we look inside the shoulder with a scope, a tool called an arthroscope, through a series of poke holes, usually about 4, sometimes 5, to look inside the shoulder, visualize the tear, clean up the damaged tissue, and repair it. And if we move over to the next slide, we'll be able to see a little bit more detail. I don't know how well y'all can see the illustration on the right, but that demonstrates a suture anchor. That's something I always have a hard time really explaining to the patient. Now they're almost exclusively made out of a hard plastic or a bioabsorbable material that is hard, about the same hardness or a little bit harder than bone. We make a little poke hole in the bone, insert that anchor, and then there's sutures that are buried or incorporated into that anchor. Those sutures are then passed through the tissue, much like you would sew a tear in your jeans. You pass the sutures through and then tie the sutures to repair the tissue back to the bone. The goal of that suture is to hold the tendon to the bone until the tendon can heal back to bone. That's a long process, which is really the difficult thing for patients when they're getting over a rotator cuff repair, is just how long it takes the tendon to heal back to bone. I often tell people that is at minimum a 3-month process, and will usually take a little bit longer than that in order to get all your range of motion and all your function back. During that time, you'll go through progressive physical therapy, and we try to make sure that we're treating the patient for other medical conditions, because certain medical conditions slow down healing. And this is where we really start harping on patients about whether they smoke or not, because smoking really impairs healing of this tissue. So we give it time, we rest the arm so we're not using it aggressively, and we have the therapist guide you through a very important physical therapy program in order to get full recovery from a rotator cuff tear. As we move on to the next slide, next slide, please. We'll move on to the next complaint or pathology, which is, the technical term is adhesive capsulitis. The common term that a lot of people will use is frozen shoulder. And frozen shoulder is probably a more accurate definition of what it feels like, because The shoulder joint itself is the most mobile joint in the entire human body. What happens with a frozen shoulder is the capsular lining, that tissue that's deep to all the muscles, that sac that helps hold the fluid in the joint, for some reason spontaneously starts to scar to itself. By and large, we don't know why this happens in medicine. It's one of those things we call idiopathic, which basically means we don't know. It's a very fancy word for I don't know why this happens. We know that it can be caused by an injury, but oftentimes it just starts spontaneously. Usually there's a period of really intense pain at the beginning. We call that the inflammatory phase. The shoulder usually has fairly decent motion. It just really hurts. And then as that pain goes away, the shoulder begins to do what we call freezing. Now, it doesn't really get cold and freeze, but that tissue scars to itself, and then the motion is progressively limited over time. The great news about this condition, although it is very much a nuisance for the patient, is that it will go away. If I don't do anything to the patient except encourage them and pat them on the back, it will go away on its own. It can just take a very long time, sometimes upwards of 2 years. And since patients don't particularly like to have symptoms for 2 years, they'll come in and see us, and there are some treatments that we have that can really shorten the length of this problem, particularly nonsteroidals, once again, to help decrease the inflammation and decrease the pain associated with frozen shoulder. Once again, the crux is physical therapy to teach the patient a good home exercise program that they can do on their own, and the compliance with that exercise program, that home stretching program, is going to be the crucial component of recovery. And we'll oftentimes use injections, not that the injections are magic, but they do decrease the inflammation and help the shoulder recover a little bit. And they also have the added benefit of stretching that tissue out by putting fluid next to it. Now, once again, time heals this particular problem, and we can't control time other than just letting it happen. But we do really strive to get this problem better a little bit faster than the typical recovery if we didn't do anything at all. If we move on to the next slide, we'll see shoulder arthritis, which is what we're seeing a picture of here. On the left, we have a drawing or illustration which basically depicts shoulder cartilage in various degrees of damage. At the beginning, nice, smooth cartilage. When you actually look at cartilage, it is remarkably smooth and slick. Think of very smooth marble, except it's a little soft. As you move on to progressions of arthritis, the tissue will become cracked, frayed, and eventually slough off. And then as that's happening, the bone itself will grow, and you'll develop bone spurs or osteophytes, which you can sort of see depicted in the x-ray on the right. On the large spurs that you'll see at the bottom of the ball that will then impinge or pinch on the socket, really causing a significant loss of motion. Arthritis and adhesive capsulitis are the two reasons that people will lose motion in the shoulder most frequently. Arthritis is one of those things that will affect people in varying degrees. Can we move on to the next slide? Patients usually notice progressive stiffness, pain that usually happens after activity. So for example, you can go out and work in the yard, or you can go do your job, or you can do all the things you normally do, but then you get in and you sit down for a few minutes and you start noticing this progressive pain. Also, after you sit for a little while, you might notice what we call post-rest stiffness. So the shoulder hurts when you first start using it, but then as it loosens up or warms up, you'll have a little bit more motion, but then if you sit down and rest again, the stiffness will recur. Pain is the crux of the problem. People will complain of pain with shoulder arthritis. They'll also say that they have a lot of difficulty sleeping, which I've already mentioned is a real key to shoulder pain in general. And I think I've already mentioned that those bone spurs can cause real blocks to motion. Not the same kind of stiffness you'll notice with frozen shoulder where it just feels a little tight, but where you'll move it and it just feels like you hit a wall. You can't go any further because that bone spur is not going to budge. As we move on, we'll discuss some treatments of shoulder arthritis. For this, therapy has not really been shown to be as effective as other treatments. We will oftentimes try a short course of physical therapy to see if the stiffness will improve or if some strength around the shoulder will help decrease the pain. But if that doesn't work, we don't continue to pursue therapy any longer. We will utilize cortisone injections for the shoulder. I try not to give cortisone injections any more frequently than every 3 or 4 months when we're treating arthritis, and really like to space them out much longer than that if possible. Non-steroidal anti-inflammatory drugs are, once again, utilized like any other time we're treating arthritis. We'll use those drugs that we treat for arthritis, such as the Advil and Aleve, and sometimes our prescription strength drugs. And then the ultimate treatment, however, is usually total shoulder replacement. Many people don't know that the shoulder is actually a joint that we can replace, but in fact, it's the third most commonly replaced joint. You've probably had a friend that's had a knee replacement or a hip replacement, but right behind that is shoulder replacement, with about 53,000 total shoulder replacements a year. And that's across the entire US, of course. The way we replace the shoulder is much like we would replace a hip. We take the ball portion off, which is damaged and has big bone spurs on it. And then we put a metal stem typically down in the arm, which helps, down in the arm bone, which helps hold the ball in place. And then we replace the roughened socket with a plastic socket. There is a special type of shoulder replacement called a reverse total shoulder replacement. And I don't want to get too deep into the description or the separation between the two, but we'll oftentimes use a reverse total shoulder replacement when we've had severe trauma, when there's been a previous shoulder replacement and the anatomy is no longer normal, or its primary purpose is if the rotator cuff is not a functional rotator cuff. If you remember when I was describing the rotator cuff a few minutes ago, one of its jobs is to help hold the ball centered in the socket. If it's not working and we replace the ball and socket still has to be held in the center. So if that's not going to be working anymore, we have to do a different type of replacement, which is why we use a reverse total shoulder replacement. Let's move on to, I also wanted to talk briefly about the cervical spine. The cervical spine is important because it's the great pretender. It'll masquerade as shoulder pain, and for that matter, shoulder pain can masquerade as neck pain. I'd like to think I get this right all the time when I examine a patient, that I always know if it's neck pain or shoulder pain, but I'd be lying to you if I told you that, because that's just not possible. There's sometimes a patient comes in and you very carefully, you get their history, you do a physical exam, you do all your physical exam testing, and you're still kind of scratching your head saying, maybe it's the shoulder, maybe it's the neck. Usually it'll let itself, it'll come to the surface if you're really confused. But this is one of those times where a good physical exam and history really comes in, because if you spend all your time treating a shoulder and the pain's really coming from the neck's not going to get better for treating the shoulder. So sometimes don't be surprised if a doctor looks at you and they've examined you and they look at your shoulder and they say, you know, I think this problem's coming from your neck, and they get an x-ray or perhaps an MRI, and then that is the source of the pain. Let's move on to the next slide. When to call the doctor. I'd love to tell you to call us all the time, but that's not feasible, and it's not practical. In reality, a lot of times people get sore. You get sore muscles if you do a lot of work in the yard, you do something around the house, you decide to start a new workout routine. Sore muscles and sore joints is something that happens to all of us. And as I'm adding on birthdays myself, I notice it's happened a lot more frequently. I sort of think we ramp up the time that we call the doctor if you have a sudden onset of symptoms. If all of a sudden you can't use your arm, you can't move your arm, you can't do the things you normally do, that's more indicative of an injury as opposed to just your typical soreness. If the soreness is associated with weakness, such that you can't pick the arm up or the hand is weak, or the arm in general, like the elbow is weak, or it's associated with significant numbness, I think it's time to call the doctor or come in and be seen. Also, if your symptoms are prolonged, it's very easy as a patient, as human beings, to put these things off. You'll notice that your shoulder hurts. You wait 4 weeks, it still hurts. You wait 4 more and it still hurts. So I tell patients, if you notice that you've got a problem that's interfering with the things you like to do, and you want to wait on it, set a date on the calendar, 3 weeks, 4 weeks down the line. If that problem's still there, it's time to get it checked out. There's no reason to just live with these symptoms when there's things that can be done about it. Move on to the next slide. Before I talk about this, I want to circle back and talk about MRIs. I didn't talk previously about MRIs and when we get them. We will oftentimes move to getting an MRI after we've gotten an X-ray and we still don't have the true cause of the problem. An X-ray is going to show us the bones. An MRI is going to show us the muscles, the cartilage, and the ligaments and tendons around the shoulder. So a lot of times a patient will come in, they'll have a normal X-ray, and their shoulder hurts, and they'll ask me the question, why can't I just get an MRI right now? And the answer to that question is you don't get an MRI right away because, as we mentioned, we were talking about rotator cuff tendonitis and rotator cuff tears and all these other things. A lot of times they'll get better with conservative treatment. So you don't need to get the MRI because it's not going to change what you're going to do. Once your shoulder pain goes away, having an MRI is not very valuable. But if the pain persists, that's when we move to an MRI. And I will tell you, honestly, there are some times when insurance companies won't allow us to get an MRI right away. And we have to know when an MRI would be approved or not approved. And so that's another reason that we don't jump to an MRI at your first visit. I meant to discuss that earlier, but I wanted to make sure we got that before we moved on to COVID-19 and what we're doing to address it in our clinic. I have a lot of patients that when they come in, now it's fall of 2020, and they say, Doc, I've been having this problem for 3 months, 4 months, 5 months, and I didn't come in because I was scared because of COVID-19 or coronavirus and what that meant. So what we've done to help address COVID-19 is we make sure that all patients are screened at the entrance. We screen them for both temperature checks as well as taking a history from each patient. We try to limit the number of people that are inside the building at any one time. So we'll ask you if you're coming for a visit that just you come if you can come alone. If you're coming with your child, then just hopefully one parent will come with the child and not bring the other siblings if at all possible. And we're going to ask you to wear a mask throughout your entire visit. All of us here are wearing masks while we're involved in patient contact. We just want to try to keep everybody as safe as possible. However, on the things that have not changed is everybody's going to have a hands-on history and physical exam. We're going to get an X-ray if needed. We're going to order any other tests that we have to do. And all those areas that we're ordering tests or are getting X-rays or all the people that are working up here, we're making sure everything is safe as possible for the patients. At this point, I feel that coming to the doctor is probably safer than a lot of the other activities you're going to do in the community. And so it's a very safe thing to do if you have to come to the doctor or if you were to have to go to the hospital. I think it's as safe a time as any now that we've gotten these screening procedures in place. I would hate for someone at this point to delay treatment and live with another medical problem because they were afraid to get to come in and be seen because of the virus. Let's move on to the next slide. Additional services we have available here at OrthoSouth is we've got 2 outpatient surgery centers. if you haven't had a chance yet, you can go back and talk and hear a webinar from Dr. Tim Cron, where he talked about how we're now able to do a lot of our total joint replacements utilizing our outpatient surgery centers, and some of the advancements that we have at the Surgery Center for Pain Control to really help surgery be more state-of-the-art and comfortable for patients as they move through that process. And they're located in Germantown and South Haven, so fairly conveniently located for most people. We also have OrthoSouth, which is a service we've had for, I'm thinking about 10 years now. That is an orthopedic urgent care where you'll be seen 8 to 8 on Monday and Thursday, Monday through Thursday, and 8 to 5 on Friday. We have an urgent care line available 24/7. So if you have an urgent or emergent situation and you need to talk to someone, we can talk to you even if you're not a current patient, and help coordinate getting you into the clinic at the next most reasonable time. Or if we feel after talking to you that you need to go to the hospital, we can help direct you in that direction, of course. But that is currently located at our Briarcrest location. And if you dial 261-7828 or 261-STAC, they'll help point you in the right direction of that service whenever you might need it. Move on to the next slide, please. I think it's time for questions, so I'll turn it back over to Melissa and see if I can answer some of your questions.
Moving on to questions that we received ahead of the event. I have a few here, and I'll just go ahead and get started and then pass it along to Dr. Gill to answer. The first question is, and I'm going to get this wrong, the acromion bone in my shoulder is very sore to the touch. What could be some common causes for that bone to be sore?
Thank you very much. Could you maybe scroll back in the slide deck until we get to the picture of the bones of the shoulder, or perhaps the x-ray? Let's go forward. That's a great, go forward a little bit. One more. Okay, so this is a good, if we use this picture on the left, the one we use for adhesive capsulitis, there are really, truly two joints in the shoulder. If you look at the top, above the ball and socket joint, you'll see where the clavicle touches the acromion. And that's called the acromioclavicular joint. And that area can cause pain as well. The acromion, which is the far, on this picture, the far left of the where the clavicle connects to the acromion, that bone up there above, directly above the ball, that bone can rub on the rotator cuff. It can rub on the bursa surrounding the rotator cuff, and you can get stress fractures or non-unions of an area that really just fails to develop in the acromion itself. And the acromioclavicular joint can become arthritic. So that, although we didn't really discuss that in detail, there are some reasons why the acromion itself will cause problems. And sometimes, very frequently, we'll address that with arthroscopic surgery, where we will either shave down the acromion so it doesn't have any bone that's pinching on the rotator cuff, or sometimes we'll address the acromioclavicular joint through an arthroscopic procedure.
Thank you. Moving on to the next question, what is the efficacy, if you can speak to it, of stem cells for treating arthritis? And if it is effective, can you speak to how costly it is and the safety?
Yes. So I will tell you that stem cells for arthritis in all joints is very new in general. It's been studied more in the knee than it has in the other joints. And it's been shown to be somewhat promising in some patients. Now, that doesn't mean it's going to work for everybody. It means it will work for some patients. We have an entire Center for Regenerative Medicine that I believe has 4 physicians who are studying and working with stem cells as well as platelet-rich plasma and other biologic injections. And they can answer a lot more of the detailed questions about this, specifically as it pertains to pricing. I'll tell you that by and large, it's not cheap and it's not covered by insurance, which is the real hang-up when it comes to these things, because they're still considered experimental. Insurance won't cover them, so they're very pricey, and that's an out-of-pocket expense. But as it pertains to your individual situation, I would encourage you to make an appointment with one of our regenerative medicine specialists, and you can get their information by just calling our primary number or looking them up on our website, and they can go over the efficacy in the shoulder itself. Like I said, it's all very new research, as well as what the actual pricing would be. You did ask about safety. The good news about whether it's platelet-rich plasma or stem cells is those cells are your cells. The way we get these cells is we take blood out of your body or bone marrow out of your body, spin it down, and then put it back into you. So compared to injecting another drug, this is your body's own material. There's the risk associated with sticking a needle inside of you, which is, there's always a risk that you could get an infection if you poke a hole in your body. But it's generally one of the safest things you can do, since you're just using your own body and your own cells and injecting them back into your own body.
Thank you. Next question. Someone with shoulder arthritis has been told, quote, just shaving off a little clavicle will help. And they wonder, are there any non-surgical options? What's the recovery period like? And they have some other questions, but I guess first, are there any non-surgical options?
Okay, yes. There's almost everything has some non-surgical options. And if we go back to, this is a great slide to be on. I hope y'all are still on this slide for adhesive capsulitis. But if you'll look at the acromioclavicular joint at the top, that joint is one of the first joints to become arthritic in the human body. You can see arthritis on x-ray in people in their 20s in that joint. That's different than true shoulder arthritis, the shoulder joint being the ball and socket joint down below. That was the joint I was talking about when I was talking about doing a total shoulder replacement. Very frequently, we'll shave off the end of the collarbone or the clavicle to prevent the arthritis from causing a problem between the acromion and the clavicle. It's not the only thing that can be done. If that's your only cause of pain, sometimes it will get better with physical therapy. Sometimes it will get better with a cortisone injection focused into that joint. And sometimes it will get better with time. But all those things can be tried prior to surgery. But if you've tried all those things and it still hurts, that is an operation we do quite frequently. And the recovery is fairly quick compared to some other things. Think in the order of 4 to 6 weeks, maybe 3 months at the most. But compare that to a rotator cuff repair, it's really a much faster recovery.
And if you wait to have surgery until the pain is intolerable, does that increase the risk of affecting nearby structures or the severity of the arthritis in any way?
In the acromioclavicular joint or the AC joint, it really shouldn't make a difference if you wait. It's hard to answer. It's hard to know exactly what your particular situation is, and I don't want to, the doctor that's treating you knows your case much better than I do. So I want to be very careful that I'm not trying to give you advice, very specific advice, when I don't know your specific situation. However, just acromioclavicular arthritis, if ignored, really doesn't affect the other joints that much. It can, if it gets big enough, the joint will get bigger as the arthritis progresses. It can start to pinch on the rotator cuff and cause rotator cuff problems. And I think that's the only neighboring tissue that it would really impact.
Next question. Has rotator cuff surgery improved over the past 10 years. Can you speak to any of the pain relief and anesthesia measures that may be different now versus a decade ago?
Yes. I believe that most of this research has really taken place in the hands of the anesthesiologists, and I've got to tip my hat to them. When I first started practice about 10 years ago, and we had interscalene blocks, which is an injection of a numbing medicine in the nerves in the neck that supply the shoulder. We had those back then, and they were effective. And now we are moving through with newer numbing medicines that are more long-acting, that help relieve the pain for a longer period of time. And then we've also come up with, or they've come up with, different drugs that they use during the time period of anesthesia, so that it doesn't, so that it decreases the pain when you wake up immediately after anesthesia. So we've really come full circle and have been able to help with postoperative pain associated with all surgery, especially rotator cuff surgery, because our goal is to decrease the need for narcotics. I'm sure you all have heard about the opioid epidemic, and we're trying to do our part to decrease people's need for narcotics as much as reasonably possible.
Excellent. Next question, where do you perform surgeries?
So in addition to the 2 surgery centers that I mentioned in the slide, which is our surgery center on Exeter Road in Germantown and in South Haven off of Airways, I will do my hospital-based surgery at Baptist Hospital, most frequently Baptist Memphis, which was the old, what used to be called Baptist East, off of Interstate 240. And then at Methodist Germantown Hospital off of Germantown Road in Poplar.
Next question, is it beneficial to do weight training to help and or prevent shoulder pain?
So weight training can be very helpful. Weight training can also cause some shoulder pain. So I want to be careful how I give this advice. As we age, we need to be more careful and judicious with how we train our bodies in the gym. When you're 18, 20, 25 years old, your body's very forgiving of injuries that incur when you're in the weight room. As you start to tack on a few more years, it can be a little less forgiving. You can ask me how I know. But I encourage people to, as you're aging and working in the gym, 1, concentrate on form. Make sure you're using proper form to lift weights. 2, have a more global approach to your strength training, so that you're not focusing on one exercise for your chest and one exercise for your shoulder, and that's all you do every time. Just like if you just did one leg exercise, you would strengthen a very small subset of the muscles and leave other muscles untrained. And lastly, I would add, in addition to sort of trying to have a more global approach to your fitness, I would say, look up, if you haven't already seen a physical therapist to teach you rotator cuff exercises, you can look them up, usually fairly easily on the internet with some reputable sources, or on the American Academy of Orthopedic Surgeons website, and you can find exercises that will help strengthen the rotator cuff, and those exercises should be incorporated into a strength training program, so the small muscles, which are deep inside the shoulder, can stay strong while you're strengthening the deltoid and the pectoralis muscles. And if you keep all those muscles strong, it really can prevent injury over the long term.
Thank you. I'm learning something. Can loss of cartilage be prevented, and is it possible to generate new cartilage?
So yes and no. That's a very, very, very broad question. There is a component of loss of cartilage. When we're talking about loss of cartilage, I'm really thinking about arthritis and the beginnings of arthritis. Usually that will begin as a cartilage damage problem. And there's a large component of that which is genetic in nature. So if your parents had bad arthritis and you start to develop arthritis, you know, especially at a young age, you're asking the question, could you prevent that? Quite possibly. We've not unlocked that secret yet. There may be something in the future that we can do, but right now we don't have anything that prevents that from happening. Some cartilage loss is because of trauma. So if you dislocate your shoulder and you keep dislocating your shoulder, you're going to have a lot of cartilage loss in the shoulder. So we will tell you that we should fix the shoulder so it doesn't keep dislocating so that you don't have cartilage loss. That's one area where we can prevent it. Now, as far as can cartilage be regrown or repaired, right now there are very few things that will truly repair or regrow cartilage. We can take cartilage biopsies, we can send them to a lab, we can grow new cartilage cells, but that does not truly have clinical applications for most people in day-to-day life in this region. It's just not something that's practical to do. By the time your cartilage has been lost in the shoulder, there's usually not something we can do to grow it back. So although there is some experimental stuff out there in the world, for the vast majority of people, it's not going to help or impact the shoulder.
Thank you. What other than surgery and pain medication can help with shoulder pain?
I think you asked, other than surgery and pain medicine, what else can help with pain?
Yes, sir. Yes.
There are a lot of things that can help with pain around the shoulder. I like to focus a lot on physical therapy. A lot of the pain in the shoulder can be posture related. If you correct the shoulder posture, how much you roll your shoulders forward versus have them up and back. And if you think about the posture that the little old school teacher was gonna slap you on the wrist for back when you were a child, that posture position is actually more healthy for the shoulder. Physical therapy, strengthening the muscles around the shoulder, can help treat the shoulder pain. Anti-inflammatories can help treat the shoulder pain, but sometimes people lump that in with pain medicine. And then cortisone injections, as we previously mentioned, can help. So there's a lot of things that you can do to help with pain. On the things that you can do in general, I will sometimes counsel people about what we call, I think a fancy word would be nutraceuticals, but what we're talking about is your herbal supplements, such as turmeric, glucosamine and chondroitin, and fish oil or omega-3 fatty acids. All of those have been shown to help some with joint pain. However, it's not the kind of thing where if you take a pill, the next day you're going to feel all better. If you want to take these supplements, I encourage people, try them for 3 weeks or a month. Stop taking them. If you notice your pain gets worse, if you got, say, chronic arthritic pain of the knee or hip or shoulder, but it's not bad enough to seek medical attention, if you try these supplements for a month, stop taking them. If your pain gets worse, they're helping. If your pain doesn't change any when you stop taking them, they're not really doing anything for you. So you could stop spending money on that supplement.
Excellent. Next question is, and you may have already covered this, what do you suggest for bone spurs in the shoulder?
Bone spurs in the shoulder, that is a catch-all term we use when we're trying to describe various things that cause problems. There's the bone spurs that I showed you associated with arthritis, and those typically we cut out when we replace the joint, when we replace the total with a total shoulder replacement. Not much else can be done for that type of bone spur. However, someone previously asked a question about the acromion. You can get a bone spur on the acromion that can cause pain. And someone asked a question about the AC joint or the acromioclavicular joint, and you can get bone spurs on that joint that can cause pain. And those can be removed very simply with an arthroscopic procedure where you shave those bone spurs off, and that can really help people that have pain associated with that bone spur, mostly because of what that bone spur is doing. That bone spur is rubbing on tissues nearby, causing pain. So if you shave it off, it stops rubbing on those tissues, and that can make people feel better. So it really is going to depend on what bone spur you're talking about. An arthritis bone spur, not much to do. An acromial bone spur or a clavicle bone spur, you can shave those off.
Thank you. I have a question here asking about the website. So I do want to take a moment just to let everyone know that our website is accessible at orthosouth.org. That's orthosouth.org. You can make an appointment online and find information about all of our providers. Select a provider that you would like to make an appointment with. We've tried to make it very user-friendly, so that's orthosouth.org. The next question is, does turmeric help with shoulder pain? And I think you may have already touched on this, Dr. Gill.
Yes, turmeric would be considered a nutraceutical, or that's what I call it. That is one of those herbal supplements which can help with pain. It has been shown to help some people, and there's not tremendous research on this. It's like glucosamine and chondroitin, or omega-3 fatty acids, which you'll find in fish oil and krill oil. I would encourage you, if you wanted to try it, and if you notice that it improves your symptoms, then stick with it, because there's not really a downside to taking it. So that's one of the great things about these nutritional supplements, is they don't really hurt you in any way, but they do cost money. So if you take them and you notice that you're not getting any better, then I would recommend you save your money and not use it. But it's going to be very patient dependent. It won't work for everybody, but it might work for you.
Fantastic. And again, thank you everybody for these amazing questions. We do have just a few more. The next question is, how often is the clavicle a major part of the problem, as when you roll the shoulder, there's popping and grinding from the shoulder all the way to the neck?
I couldn't really give you a percentage of time that it's, I couldn't say it's there 10% of the time or 15 or 20% of the time. It is something we often assess and address. If the clavicle is broken, that's a different story. That's not what you're asking. Having pain in the acromioclavicular joint is something we see very frequently. As at the acromion, where the acromion rides over the rotator cuff, you can get a lot of popping in that area as the bursal tissue slides underneath the acromion, and you'll feel it all across the shoulder. So it's hard to know exactly where your popping is taking place. Rarely, if you track the clavicle all the way up to where the clavicle runs into your chest, it mates to your breastbone right there in front of your neck. And very rarely you can get some inflammation in that joint, which will pop in that area, and that can be a real nuisance as well. So although it happens not infrequently, you will see all of those areas of popping in the shoulder on a fairly regular basis. The good news is they can almost always be treated and improved with appropriate treatment.
Awesome. Next question is, can you touch on a superior capsular reconstruction and when it is indicated?
Yes, superior capsular reconstruction is a very highly specialized operation to treat a very specific problem. So we talked about rotator cuff repairs. Rotator cuff repairs don't always heal. Or perhaps you tore your rotator cuff in January, and because you were nervous and there was a global pandemic and you didn't come in, and you come in August, the muscle has already atrophied. So me trying to pull the tendon back over to the bone is not going to work. So in a case of a person who's failed a rotator cuff repair, or they have what's considered an irreparable or a rotator cuff tear that we cannot repair, what do we do in those situations? And a superior capsular reconstruction was designed to treat those patients in that group that also are too young for a reverse total shoulder replacement. A reverse shoulder replacement was designed for those patients, but we want to reserve a reverse total shoulder replacement for older patients. And I'm not going to give you just a set age, but just older patients or when we want to do that. But it's the superior capsular reconstruction is a salvage procedure for younger patients that have a rotator cuff tear that cannot be repaired. And it's a little too complicated to describe exactly how it's done for this particular webinar, but it involves putting graft tissue in the shoulder to help hold the shoulder down in its normal position with the ball next to the socket so that the other still functioning muscles of the rotator cuff can move the shoulder even though the supraspinatus and some of the infraspinatus are not functional. I hope that answers your question.
Great response. Next question is, what do you learn from a CAT scan?
A CAT scan is something we'll use. I touched on MRI. An MRI, let's talk about what these look at. An MRI looks at the soft tissues. So labral tissue, cartilage, rotator cuff, and the muscles around the shoulder. A CAT scan or CT scan is basically a computerized X-ray. So we're looking at the bony structures, or we're getting a three-dimensional picture of the bony structures. Sometimes we'll have to inject dye into the shoulder along with a CT scan to look at the muscles and get a picture of the muscles. If, let's say, you've got an older pacemaker that can't go through an MRI, we'll use a fancy CT scan to look at the muscles instead of an MRI because you can't have an MRI. Or if you've come to see me because you've got shoulder arthritis and I want to get a good three-dimensional picture of the ball and socket joint before I proceed with a total shoulder replacement, I'll get a CAT scan or a CT scan to give me that three-dimensional understanding so I can plan the surgery and tailor it specifically to you. But that's what we'll use a CT scan for in the shoulder. I'm sorry, I should also mention, we also use it in times of trauma when we want to understand, once again, in 3 dimensions, what is the fracture around the shoulder like, and then what do we need to do to repair that fracture?
The next question asks, what are the symptoms when a shoulder replacement begins to expire or fail? And how is it addressed?
Well, I'll circle back around to failing shoulder replacements. The great news about the technology surrounding shoulder replacements is it continues to evolve. So we're anticipating that shoulder replacements will last longer and longer and longer. The weak spot with shoulder replacements has often been the socket, where we glue the plastic piece into the socket. And the life expectancy has been quoted as anywhere from 10 to 15 years. And we quote it based on survivorship. So 90 to 95% good at 10 years. But people often live many more years, over 10 years after their shoulder's been replaced. The symptoms of a failing shoulder replacement can be loss of motion. It can be feelings of instability or feeling like the shoulder's slipping out of position. It can oftentimes be pain. Pain is the thing we'll usually have people come in and complain about, as we'll say, my shoulder has started to hurt again, and that's the first indication that we're having a problem with the shoulder replacement.
Next question is, could you talk a little bit about the relationship of RTC tendinitis and biceps tendinitis?
Yes. I think from where we are on the slide, if we go up a couple of slides to where we're talking about rotator cuff tendinitis, keep scrolling up. Oh no, I'm sorry, the other direction. Go forward one to where it says rotator cuff tear, because that's a better picture. All right, so if you look at the picture on the right, this has a torn rotator cuff up at the top, but you see the biceps right there in the front and the biceps splits, you have two tendons that come up. One goes over here on the right, or to really the middle of the picture, to that bone called the coracoid. Now, that tendon hardly ever gives us any problem. But the other one that slides up right next to the rotator cuff goes into the shoulder joint, that biceps tendon can oftentimes get inflamed and it can rupture. Now, as you see, it is really close to the rotator cuff. So if your biceps tendon is inflamed, it's going to have symptoms very similar to rotator cuff tendonitis. And if your rotator cuff is really inflamed, it's probably going to make your biceps tendon inflamed, because these tissues live next to each other. They basically live very close to each other in the same apartment, so to speak. So they're going to annoy each other when one of them is irritated. We sometimes have to surgically address biceps pathology when we're looking at a rotator cuff problem. But it is not as often that we have to treat that surgically. We can treat it with during the same operation where we're doing the arthroscopic repair of the rotator cuff. We can address the biceps tendon at the same time.
Thank you. And we do just have just a few more. Does Medicare now allow for same-day joint replacement?
So Medicare allows for outpatient total knee replacement right now. Total hip replacement is considered, they're investigating it. We anticipate that in 2021 that total hip replacement will be able to be done as an outpatient for Medicare rules. Total shoulder replacement is still considered an inpatient only procedure. CMS or Medicare has not said whether they plan on looking at it in 2021 with the hopes that it would move to outpatient status in 2022. We have no indication from them as yet what they're going to do about total shoulder replacement. I was really hopeful that they would accelerate this in the face of the COVID-19 pandemic, but they didn't even touch on it. So we have no indication yet as to when they're going to let total shoulder replacement be an outpatient procedure. Right now, total shoulder is inpatient only.
Excellent, thank you. The next question, and we have about 3 more, are what are the negative effects of cortisone?
The negative effects of cortisone. A lot of the negative effects of cortisone come from our patients who've had to be on long-standing prednisone for disease processes like rheumatoid arthritis. That has a lot of different effects on the tissue, weight gain, etc. What we're talking about is a cortisone injection. And cortisone injections are thought to be reasonably safe. We don't want to do them over and over and over again because the cortisone can have some weakening effects on the connective tissues around the shoulder. We've got some research that says if you have many more than 3 cortisone injections in the shoulder to treat rotator cuff tendonitis, which is one of the first things we talked about, if you have more than 3, surgery has been shown to be less effective. So if you have rotator cuff tendonitis, we'll tell you that we don't want to treat you with more than a few shots in the shoulder. If you have a rotator cuff tendon tear, it's been shown that if I treat you with a rotator cuff or with a cortisone injection and then immediately go to a rotator cuff repair, that repair is not usually as effective. So we'll usually want you to wait a month or more after a cortisone shot before we move in and do a rotator cuff repair. So if I know you've got a rotator cuff tear, I oftentimes won't treat you with a cortisone shot if I think we're going to do surgery in the near future. For shoulder arthritis, the long-term effects are not really as significant. However, I won't, anywhere from a month to 3 months after your cortisone shot, I'll want those tissues to rest before we do a total shoulder replacement, because cortisone decreases your body's immune response, and we don't want to run any risks of increasing the likelihood of an infection after surgery. So we'll want to give your body a rest period after a shot. before we proceed. But the effects of cortisone, by and large, depend on what we're treating with the cortisone injection. The old catch-all term that it weakens tissues or weakens the bone, that's really associated with our long-standing prednisone patients that were being treated with an inflammatory process. So that's not exactly as applicable. It's not an apples-to-apples comparison for our regular cortisone shot.
Thank you. So the next question is submitted by someone who says that when they sleep on their sides, their shoulder seems to slip from the socket, making a noise. And they wonder what could be the reason.
That's really hard to say. I say if you feel like your shoulder's slipping out of socket when you're sleeping or when you're laying on your side, we need to get you in and examine you specifically. I mentioned a couple of things that hurt worse when you lay down. All shoulder pain hurts worse when you lay down. That's common for all shoulder problems. But a shoulder that's slipping out of the socket when you lay down, that's unusual, and we need to examine you, get a good history, and possibly and definitely an x-ray and maybe some more specific studies to see why that's happening, because that's a very unusual complaint.
Thank you. And the last question for Dr. Gill is, what is the difference between impingement and frozen shoulder?
So let's start with the slide we have right in front of us. Impingement falls into the treatments associated, or the conditions associated with rotator cuff tendonitis, rotator cuff inflammation, bursitis, all of those things. If we look at this slide here, where the rotator cuff tendon tear is on this picture, that's where part of the humerus, or the ball in the ball and socket, is called the greater tuberosity. That's a little bump where the rotator cuff attaches. And as you elevate the arm, or you pick your arm up like to wave to somebody or to put your hand over your head, that bone moves up and can impinge or pinch on the acromion, which is the bone that's part of the scapula. It can also pinch the rotator cuff between those two bones. It can pinch the bursa between those two bones, and that's what we call impingement. Usually it's associated with an overgrowth of the acromion, which someone else had asked about bone spurs. Commonly we'll refer to it as a bone spur, and then we'll treat that by shaving that bone spur off. Now, frozen shoulder has to do with the capsule, or the lining of the socket, and it becomes inflamed and irritated. We don't know why it happens. It happens spontaneously, and then it scars to itself. And that scarring will go on for a period of time and then goes away, oftentimes on its own. But we treat it with stretching, shots, and anti-inflammatory medication to help break that scar tissue up and then let that shoulder return to normal. It usually returns to normal after a frozen shoulder, but that's the difference between impingement and a frozen shoulder.
Thank you so much, Dr. Gill. That is the conclusion of our presentation and our question and answer session tonight. As a reminder, this session has been recorded, and it will be shared on our website and across all of our social media channels within the next couple of days. So you can access it on our website at orthosouth.org and go to About Us under the News section. We'll also be sharing it via our Facebook page, which is at OrthoSouth Care. So be sure to like and follow our page. And I will also add a link underneath this event on the Facebook page as well. Feel free to email us. My email is mkandel@orthosouth.org. If you are interested in any more information or would like me to email this presentation to you once it's completed, that's mkandel@orthosouth.org. And Dr. Gill, thank you so much. Is there anything else that you'd like to say before we wrap up?
No, thank you very much for giving me this opportunity. I appreciate everyone's attention, and look forward to talking to you guys again in the future. Thank you.